So welcome everybody, as always. And so today we're going to talk about epilepsy and uh, behavior problems and developmental disabilities. But just before we get started, I just want to remind people a couple of things. So first of all, upcoming events. So we have on April the 9th, so the first second Wednesday of April, Julio Martinez Trujillo is going to be doing a presentation at our rounds. And then our annual spring Continuing Professional Development Day is on March 27th at Ivy on Windermere from 12 till 4 and includes lunch. Jason, how much room do we have left?
We don't have any room at the moment. We are at capacity.
Okay, so we could we'll see, we'll start a wait list, and if people wish to bribe us, we can kick somebody else out.
Deal.
Um, and then I think Jason has also sent out a notice about our annual research grant if anybody's interested. And it can be found on our website. But Benjamin Goldberg Research Grant competition is happening, and the deadline is at the end of this month. Let me just see if Egidio got back to me, and not yet. So what Egidio and I have a number of patients. Actually, you know what? So let me just I will reintroduce Egidio when he joins us. But so Dr. Spinelli is a pediatric neurologist at University of Western Ontario and at London Health Sciences Centre, who has actually worked literally from coast to coast in Canada. So he did medical school in oh, where did he put it? I had a second. At the University of British Columbia, and I think he did his residency in Toronto. Although I'm not, it's either that or Hamilton. Although don't quote me. I might be making that up entirely. Um, but and then he actually did a postdoc, worked in the United States for a few years, and then worked in Hamilton. Sorry, in Halifax before moving to London after a year in Halifax. So worked in British Columbia and in Halifax. So from coast to coast. And we're lucky now to have him. And he and I share a number of patients together who have problem with behavior problems as well as epilepsy. And so one of the things we always, from as a psychiatrist, I always try to figure out is what is safe and what's not, what's going to increase the risk of seizures, what's not going to increase the risk of seizures, and things like that. And I know I've talked with Miriam Nouri a fair bit about this as well, in terms of ADHD symptoms and things. So what we're going to do today is we'll do a case presentation around a patient that Egidio and I share, although he has been anonymized, and then we'll have hopefully lots of time for discussion. So I am going to share my slides here. Okay, so I think Egidio was of the belief that you guys wouldn't be able to see us, although I'm not sure why. And oh, I don't know what. Anyway, so we had pictures of Javier Bardem, who I think Egidio's wife thinks he looks like, and then I guess he believes that I look like Jude Law, which I would like to believe too, but I'm not sure Jude Law wants to believe that. Anyway, so we're going to talk about aggression, epilepsy, and developmental disabilities, and how we approach these things. Oh, okay, there we are. Sure, I can see the resemblance. From Egidio's perspective, he has no conflicts of interest. I have grant funding from several publicly funded agencies, Ontario Brain Institute and Brain Canada, and then two private interests, Hoffman LaRoche and MapLight Therapeutics. But those grant funding will have no impact on the presentation today. And I think this was in the notice that Jason sent out, that at the conclusion of our presentation today, the learning objectives are here for everybody to see. Just want to see this. Okay. Thanks, Farah. So Jason, I don't know if you want to get in touch with Egidio, but Farah just said that Egidio wasn't able to log in, so he might need a new link also.
Sure thing.
Oh, Farah, he shouldn't need Duo though if he's, well, anyway, I'll let Jason sort that out. If you look in that question and answer, there's comments there from Dr. Abdul Sadr, Jason. Okay, um, so we're going to talk about this young man's patient's developmental history, the behaviors he's had, and then the development of seizures and how they've been treated. So we will call this guy Bob Sacamano, who may be known in other contexts, at least that name. So he's now a late adolescent male, although I've known him for a number of years. He attends a developmental program in a local high school, and he lives with his parents and two siblings. One is older and one is younger. Uh, and he was referred to me initially for a review of his treatment and diagnosis as well. So just his early developments, his parents said that their initial concerns arose when he was about 18 months of age. And his parents noticed that his early development just seemed to be very, very different from that of his older sibling, that he didn't respond to his name when it was called, and he didn't use any words till well past the age of 2. And even then, they weren't really used communicatively. And at our very first appointment, his parents said that looking back, they noticed from a very, very young age that his development just didn't seem right, and it never did. So he started in a speech and language. He started in speech and language therapy at about 3, and he saw a pediatrician actually who referred him to a speech and language program, and then people at speech and language therapy wondered about other explanations for his language delays. He was referred to another pediatrician who thought he might have autism but wasn't convinced of it and wasn't sure, and so diagnosed him with a language delay. But later on, when he was in kindergarten, he saw a second pediatrician who diagnosed him with autism spectrum disorder. He was involved in the provincial intensive behavioral intervention program for a while, and had some gains, although not as many as we might expect in other people. So one of the things that his parents had noticed was that starting at a very young age, at about 6, he had some really significant repetitive behaviors. So doors had to be closed, particularly car doors. And if he saw any car with its door open, he would go over and close the door, regardless of whose car it was. And apparently, at one point, his parents were sitting somewhere and they were outside somewhere. And there was a police car with one of its doors open and a couple of police officers sitting inside. And this person, Bob, went and actually closed the doors on the police officers, which I guess caused some uncertainty on their part. Also, at home, there could be nothing on the dining room table except the food that was going to be eaten, so parents couldn't leave books or other things there. And any playground that he went to before he would play on it, he had to walk all the way around the perimeter before he would do anything. And if his mother's cell phone wasn't in her front pocket, if she wasn't using it, he became quite agitated. And so with this ritualistic behavior, when he was younger, there wasn't really a lot of aggressive behavior, but he got very, very upset if his rituals were stopped or if they couldn't be followed. And he would scream and throw things, and he would throw himself to the ground. And as time went on, it began to happen more and more at home and at school. And his parents, even in kindergarten, were asked to pick him up repeatedly, or his grandparents were from school because he was so upset and couldn't be consoled. As Bob got older, his behavior became more difficult to manage as he got older and bigger and stronger. And unfortunately, because of the fact that he got upset quite often around routines and rituals, especially, that because of the unpredictability of what might happen, his parents found they were able to engage in activities less and less. And so he was missing out on things. So his parents initially had approached me about the possibility of using medication. And I think I'd written them prescriptions for a couple of medicines at their request. Uh, Before they actually did anything with the first couple of prescriptions. They never filled them, I don't think. But at the age of 9 or so, the aggression itself became more prominent. So he started hitting the bus driver, and if they didn't stop at McDonald's when he wanted them to, he was started to be sent home from school for hitting and grabbing people. And at home, there were daily episodes of aggression. And even though this person is now in late adolescence, he never attended school for a full day. It was mostly half days when he was younger, and for a reason we'll come back to in a little while, he's been out of school for a few years now. Um, at the age of 9, cognitive testing revealed a significant intellectual disability. I think that he was perhaps diagnosed at the time with a moderate intellectual disability. Realistically, it's more in the range of severe, because his nonverbal intelligence was at the 0.1 percentile, his 0.01 percentile rather, uh, and his And his verbal intelligence was also at the 0.01 percentile. So that means his score was equal to or better than 1 in 10,000 people. And his full scale intelligence was actually at the 0.003 percentile. So quite disabled cognitively, without a doubt. Um, anyway, so ultimately, because the aggression had gotten worse and he was being sent home from school, he was started on risperidone at the age of 10. And what his parents reported initially was that there was certainly a reduction in the aggression and agitation, both at home and at school. But as the dose was increased to 1.5 milligrams daily, which is what I normally aim for with people, his ritualistic behavior increased dramatically and consisted more and more of touching things. So he would, anything around him, he would walk around and have to tap on things or touch them. So at one appointment in my office, he walked around and he tapped on the walls and on the bookcase and on the door. And in fact, his parents said at restaurants, he'd gone up and started touching people's tables, tapping on them, and actually tapped on a few people. Um, some of their rituals that became more prominent also became much more complicated and convoluted. So at times when he was walking by in his house, he would walk by a room, open the door because it had to be closed previously. He would open the door, would have to touch the carpet, and then would close the door, and then would go to the next room and things. So his parents and I at the time talked about what to do because he was doing certainly seemed to be doing better with the aggressive behavior, but the ritualistic and repetitive behaviors had become worse and created in a lot of ways more problems for them. And we talked about the potential to start an SSRI to see if that would reduce the repetitive behaviors, although there's not a lot of good evidence that they will. And ultimately, his parents decided they would just discontinue the risperidone and see what happened. So when we reduced and discontinued the risperidone, the repetitive behavior went back to where it had been previously, but also the agitation and aggression did. So we were back exactly where we had started. So over the next few years, he was on several antipsychotics. Now, there was a lot of discussion about each medicine and a lot of uncertainty about whether it was beneficial or not, and a lot of data keeping. But really, not many of them were of benefit. So he was on aripiprazole, he was on haloperidol, he was on brexpiprazole, without any real benefit. And he also was, because of ongoing problems with attention and concentration and restlessness, he also took methylphenidate, I think in the form of Concerta, and then Vyvanse, as well as Strattera and Intuitive. Again, none of them really made anything worse. Or sorry, none of them made anything significantly better, and were all stopped within a few months. As he got older, so at the age of 13 or so, his aggression increased dramatically. And his mother described the previous 6 months as the worst of his life and really had become problematic. I had an appointment with this person and his parents by video because at this point in time it was in COVID, and they were actually at the front hall of their house having to restrain him because he'd become really agitated and become very, very aggressive towards his father, who seems to bear the brunt of the aggression, unfortunately. So at that point, his parents and I talked about what we could do and the fact that other antipsychotics hadn't been all that helpful. But his mother said she had read something about olanzapine and wondered about that. And so we started him on it and gradually increased it. And his parents actually initially reported there was a fairly dramatic improvement actually in his aggression and in his mood. There was significantly less aggression, it was less impairing. They could again go out and start doing more things with him. And also his mood seemed better. He was happier. He was just more what they recall him being when he was younger. So he was more like himself, which was great to see. Unfortunately, as time went on, and it's not, well, it may be clear why, but he began to have more and more problems. And again, at this point in time, he was only going to school half days. So in the summer before he started high school, his aggression increased dramatically, as did the repetitive behaviors. And to the point that his father was getting hit pretty regularly. Sometimes he would be woken up in the middle of the night being hit in the face. And yeah, I mean, I've got a seminar right now. Yeah. His parents also noticed that he was being more and more bothered by sensory issues. So he didn't want to wear clothing in general a lot of the time, and textures that previously hadn't bothered him, and certain clothing he began to have problems with. So he started to have a lot more sensory issues, which hadn't been a huge problem when he was younger. And then right around in August of that year, we had an appointment, and his parents said, in the last few months, we've noticed he has these kinds of episodes where he is, in the middle of what he's doing, he'll just stop and will just stand there for 10 or 15 seconds. And sometimes it would, and often actually it would interfere with the flow of what he was doing. So he'd be doing something and it would just stop. And then after 10 or 15 seconds, he would sort of pick up again. And he would stop in the middle of an activity at times and just stand or look ahead of his stand and would sometimes squint through his eyes. And his parents had never noticed him doing that before, and certainly I hadn't either at appointments. So we ordered an EEG, and it took a long time, unfortunately, to get it done for a variety of reasons. Um, uh, Actually, and this is where well, what it actually showed was he was having absence seizures. And I think during the actual EEG, I think they recorded 4 seizures, if I'm not mistaken. Uh, Jason, what's happening with Egidio?
I'm
Are you there
here.
with us?
Oh, well, welcome.
Can you hear
So,
me?
yep,
Uh, Sorry about that.
that's it. How are you, Egidio?
Oh, very good. I think like Duo is down for everybody, so we essentially can't log into our many people can't log into their hospital accounts anymore. So there you
Uh,
go.
but
But
just so you know, the name under your video right now says Farah Abdul Sadr. So Farah
yeah,
looks a
yeah,
bit
no,
different than
no.
usual.
I'm suddenly become much more intelligent.
That well, and well, much more feminine also. You're in touch with your feminine side, as they say. So, so I just had gotten through a video just talking about literally up until your section, so it was perfect timing.
Yeah, sorry about that.
So, yeah, that's fine. So why don't we just take a couple of minutes? So did people, were there any comments or questions about his behavior problems and their presentation? And we talked a bit about his cognitive testing and things. So if people would like to, now where is oh, it's on the topic. Okay. So Sharon Lawrence, all you have to do is unmute yourself and you're good to go. Hello? Uh, Sharon, were you, because I think I gave you permission to speak, which sounds ridiculous, a ridiculous thing to say that I gave you permission to speak, but that's what it said I did. But I can't hear you for saying anything. If now it says I have to ask, I need you to unmute yourself. There we go. So I'm not
Sharon,
sure.
your microphone might not be working. There's a little up arrow beside the audio button. You might need to select a different microphone.
I think all these cuts probably are related to the current difficulties in the United States with educational things being cut. So it's affecting us in Canada now too. Tongue in cheek, I say that. Sharon, if it's easier, if you just want to type it into the Q&A or something like that, if you're having a problem, that's fine. While we're waiting for Sharon today, were there other comments or questions? So I could say that, in terms of his presentation, I should have done some mental status stuff. So at most of our appointments, he would sort of greet me very superficially and only when his parents sort of prompted him to, and really didn't engage in any play in the office, didn't really initiate interactions with his parents or myself other than to ask for his parents for things or when they were going to leave. And some of his speech was certainly delayed echolalia. So there wasn't a lot of communicative speech. There was a fair amount of delayed echolalia when he spoke. And as he got older, it was quite interesting watching because just as the aggression got worse at home, it has gotten worse. Just watching his parents, they've become much more on edge now, or much more tense, I suppose, during appointments, and bring lots of things to keep him busy. And even with that, he certainly has headbutted his dad a few times during appointments. And I think with all this, and particularly with his dad being the brunt of things, his dad actually looks really stressed and has not looked well, I would say personally, for quite a while now. While we're waiting to see if Sharon can speak, there we go. Okay. So, did we do any pharmacogenomic testing for CYP2D6? No, we didn't. but I mean, he has had genetic testing, which Egidio will come back to. But why do you ask about that? Because I think that regardless, with the problem with the risperidone was that it seemed to help him, but it caused a lot of it seemed to make ritualistic behavior worse. And I think, and there are some reports in the literature about OCD becoming worse with risperidone. So shared responsibility, olanzapine worked, but risperidone didn't, and it might have something to do with the metabolism and the 2D6 enzyme system. But I also want to just be about the the chemistry and their pharmacodynamics. But as well, he was probably uh, what 3 years older or so, and I don't know if that had anything to do with it. So I don't. He's never seen a pharmacologist, but it's an interesting question to ask, and we'll come back to that in a bit, maybe with when Egidio was talking about the seizures and how difficult they were to treat. That's a good idea though, Sharon. Thank you. There other questions or comments people had? Because if not, we can move along. Okay. Uh, Egidio, do you want me to unshare it and then you can share it, or what would you like to do?
Um, so I share mine.
So right now, the slides that you sent me is what I've got up. So you can
Yeah.
you can tell me to move the slide ahead, or I can, if you want to share it on yours, I can stop sharing and then you can share it. Which would you like to
Uh,
do?
would it be okay if you may I ask if you might be able to go ahead with it?
I think I can do it. Yep.
So I'm
Uh,
afraid of what happens if we log out.
there we go.
Um,
Yep.
so we first met him at 17 years of age. I'm actually in the emergency department after he had gotten his EG, so he would have been 13 years of age. Sorry, I apologize. We saw him when he was 13, but now he's 17. So I apologize. And if you could please go forward.
Yep.
If you maybe just click the whole thing and then I'll just, yeah. Oh, yeah. And at the time he had the diagnosis of so autism, global developmental impairments, and also motor tics. And then it appears that he started to have spells concerning for seizures at about 11 to 12 years of age. And there were three types that the parents described. There was staring and blinking repetitively. There was activity arrest. And then afterwards, he would almost be unsteady and would have to rebalance himself. And then there would also be times where he would roll his eyes to one side and be unresponsive to verbal or tactile cues. And if you could please go forward. And these would have been the medications that he was on at the time. And the clonazepam was being given for behavioral issues. And next slide, please. Pregnancy, I think, was unremarkable. Birth, uh, um, uh, yeah, that's right. So it's 38 weeks, some fetal distress, failure to progress, an emergency cesarean section. But then actually the postnatal course was rather unremarkable. And then the development was delayed. So you would have been diagnosed, pretty close to probably before 1 years of age or so, or sorry, after 1 years with autism. And then uh, um, I guess first words at 1 year of age, maybe a little bit delayed. Walking at 1.5 years of age, it can still be within normal. But the bottom line is there were delays.
So Egidio, and in my presentation, I said he didn't have words left too, because for me, mama and dada don't count as words. And so I think what I'd seen when he was younger, in terms of using words meaningfully, it was well over two. I think he might have had a few sounds before that, and mama and dada, but I don't think those are words usually.
Yeah, and so when I'm saying first words, I'm referring to, yeah, you're correct. It's dada and
Yeah.
mama. Yeah. I think next slide. Um, there's mom is healthy, dad has OCD, and there's many members of dad's family that have OCD. And I think Dr. Nicholson mentioned that dad's got some pretty severe OCD. There's some family history of epilepsy. So mom's side of the family, somebody who has tonic-clonic and absence seizures, but a third cousin. And then dad's on dad's side, there's a cousin that has absence seizures. So nobody really in the first degree. So the question is for him is how do you tell the difference between staring episodes that are seizures versus not, with or without tics? And this was quite challenging. And in fact, if had Rob not gotten the EEG, I honestly wouldn't have been able to tell. And the parents were also not able to tell what was a seizure and what was not. It was quite something. If you could please go to the next. Um, and then the other question was also, he's on all these medications, and well, how do you tell the difference between that and seizures? So for him, definitely an EEG is without an EEG, we would have probably just never been able to tell clinically. Um, and right, and in some kids you essentially can't tell. So the bottom line is those episodes that we described, those 3 episodes, I think they were basically all seizures. And so um, at some point we actually got mom to come into and maybe dad too came into the hospital, and we showed them the EEG and we went over the seizures. And even then it was hard for us to tell what was a seizure and what was not. And what was interesting is sometimes he would have these absence seizures, and as time progressed, that motor tics would actually start to happen. And sometimes he would have the motor tics without seizures. Essentially, it was almost impossible. And he's one of the children where without an EEG, you can't actually tell if there's improvement or not. Next slide, please. So the first EEG showed absence seizures, and I think, as you noted, there were about 4 or so. There was some blinking during the events. Um, he did have some investigations, so some genetic investigations. There was an inherited change in at 7p22.1, which was thought to probably just be of unknown, uncertain significance. MRI was unremarkable in 2022. Um, and then, so this is where the fun began. So he was started on ethosuximide, and then this actually seemed to help, but then he started to have behavioral side effects. And behavioral side effects are essentially all of the side effects that Rob has been dealing with. So all the behavioral issues, the anger, all of those issues. And then we went to lamotrigine, and that resulted in him having episodes of opening and closing his jaw repetitively. Then we went to levetiracetam, and if anything, actually interestingly, levetiracetam increased seizures. Then to clobazam, because we thought it might help. But if anything, increased seizures. Valproic acid was partially effective, but then actually increased his appetite and caused behavioral side effects. And if you could go to the next slide, please. Um, and what was actually interesting was that partly he was already on clobazam, and so sorry, clonazepam, and actually he was getting clonazepam quite regularly. And it turns out I spoke with probably both Dr. Levine and Dr. Prasad, and it turns out that historically clonazepam has actually had very good treatment for absence seizures. It's just the problem is most kids can't handle it because of the side effects, and at high doses they can't. But actually, because he was already on clonazepam and his father's on clonazepam anyways, we just made it a regular thing. And it actually seemed to help with some of the absence seizures and some of the behavioral side effects. But then unfortunately, he started to have generalized convulsions. We thought, okay, well, maybe brivaracetam, but like levetiracetam, it caused worsening of seizures. So likely is some strange class effect for these medications. Um, we tried lacosamide, which actually was helpful for the generalized convulsions, but then didn't it resulted in behavioral side effects. And so finally we ended up with topiramate, which seemed to control the convulsions. He's on a low dose, and it's a combination of topiramate and sorry for the screaming outside, uh, the the clonazepam, which seems to be doing the best. Now, the kicker is he continued to have episodes of eye fluttering and blinking, but if you could go to the next slide, the so there was sorry, this was another EEG, but then if you go to the next, by 2023, oops, yeah, 23, so there should be 3 EEGs here. They'd actually all become normal. And there was one that was 8 hours. He actually managed to keep it on for 8 hours, which was remarkable. And so then all of the staring episodes and the blinking episodes, which essentially are no different than the ones they used to have, are now not seizures. So there you go. Next slide, please.
And if I could just say, Egidio, and it was in retrospect, I wonder, and I think that is, I talked about this with his mom, and is that because during appointments prior to this, he would sometimes, just stop and look at me, and I thought he was actually looking at me and thinking about something. I'm not sure what. And in retrospect, his mom said she wondered if those had been seizures all along and that we just hadn't realized it.
Yeah, and that's a good question too, right? Like when, like supposedly these started at 11, 12 years of age, but maybe they'd been going on for much longer.
And his
I
parents
think,
didn't even bring
mhm.
it to my attention, I think, till he was 13 or so, right? So there's that gap, and I think they probably weren't aware or weren't sure.
And again, we sat in at night, we brought them in after work, and then they were sitting in front of the computer, and we were running the EEG, and we couldn't tell. We just could not tell the difference between a real, like an ictal event and a non-ictal event. They all just seemed the same to us. It
And,
was
and,
quite
and I think
amazing.
this is a difficulty in I think in people with autism or people with limited to no verbal ability, is to just, because sometimes people are just looking out the window or whatever, but other times they might not be, and we don't know.
And if I may, like we tell also, like the classical thing we tell people is, well, you pinch them or you throw something at them or you spray cold water on them, and if it breaks the seizure, if it breaks the spell, it's not a seizure. But with him, you could probably pinch him and he wouldn't, no effect whatsoever. So
Out of curiosity, what would the College of Physicians and Surgeons say about those approaches?
they are, oh, I guess now it's on. Oh shoot, I shouldn't have said
Well,
that. But I
especially
think
the throwing water at people too.
the bottom line for me anyways, and I can't speak for the other neurologists, is I do whatever I can to get them to abort the spell.
Yep.
And so, tickling, sometimes I pinch people like in, when they're really poor. But one mom, for example, suggested taking a water, like a spray bottle, and just spraying cold water into somebody's face. And um oddly enough, a lot of parents are under the, I don't know where it's a myth, but a lot of parents say, well, I didn't know we were supposed to touch them. It's like, no, absolutely not. You actually want to abort it. But yes, the college may have issues with that.
Well, I was about saying that tongue in cheek mostly, but uh here, okay. Yep.
So there's just some just information that everybody may know, but about 20% of people on average, and the numbers are quite varied. It's a bit of a broad scale, but autism have epilepsy. And interestingly, the rate of misdiagnosis is actually quite high vis-a-vis um, this patient. There appears to be two peaks from what can be gathered. There's adolescents, so young children, and then a larger number of people in adolescence. And definitely, anecdotally, from what I can tell, that is true. That a lot of children, at teens that have autism will start to have seizures. Um, and um, the the rate of epilepsy is higher in individuals that have intellectual disability and autism, and then 8% of, so the numbers are a little bit less in children that have autism without intellectual disability. So then you think of the children that have autism and have epilepsy early on, and they're usually the ones that are much more affected by the condition. And then the other really important thing to warn people, and we always do this too, is that about 20 to 30% of individuals with autism will have epileptiform EEGs. And out of those, I think it's 10% or so will actually have epilepsy. So again, going back to the fact that the EEG is helpful, but it doesn't necessarily, again, in this individual's case, it was pretty clear and straightforward, but you can get a lot of false positives. Next slide, please. Oh yeah, right. And there's no predominant seizure type present, so you can have focal or generalized. There doesn't seem to be one specific thing. And again, from my experience, individuals that you get a 17-year-old that you think, oh wow, he's got to have focal seizures, and you start him on a medication, and their EEG shows generalized, and then the next boy, you think, oh, he's got generalized seizures, and then his EEG shows focal. So it's very hard. The history is very hard. Sorry, next slide, please.
Yep. Do you want me to
Uh,
talk about this briefly, Egidio?
oh yeah, that's yours. Yeah, yeah, yeah. Please go ahead.
So a question. I think every psychiatric medication, if you look at the product monograph, they all say that they can lower the seizure threshold. And I've never entirely been clear what that, I mean, I know what it means, but I don't practically know what it means. And so there was a group, this about, what, 15 years ago now, and they went to the FDA and they got clinical trial data on essentially all of the psychiatric medicines available at the time. So their total sample size was not bad at 76,000 subjects. And they were able to look because then they had people in all these clinical trials. There was a placebo group, so they could look at the rate of seizures in people who had who were taking the medication versus people who weren't taking medication, so were on placebo. And what they found was that there were a few medications that clearly did increase the risk of seizures. So I think so we know for sure that I think it's well known that clozapine can and bupropion as well. I wasn't aware at the time that olanzapine increased the risk of seizures, and there was evidence as well as clomipramine. And I was saying to Egidio yesterday, I'm a bit surprised that alprazolam was seen to be associated with higher seizures, given that it's a benzodiazepine. But I wonder if that would be withdrawal or something like that, because of the short half-life. And interestingly, what they also found was that the rate of seizures in people taking SSRIs was actually lower than people taking placebo for some reason. But ultimately, it says that even though there's theoretically a risk with all psychiatric medicines, there's a few that for sure do increase the risk, and the rest probably really don't. The one caveat to this is that all the subjects in these trials were people who did not have epilepsy to begin with. So these are people with new seizures, not people who had previous seizures. And there you go, Egidio.
So there's a lot of uh, a lot of people are afraid or scared to start medications for ADHD, and I guess maybe I'm biased, but the papers that I could find don't really find a very close association between initiation of medications for ADHD and having epilepsy. I suspect you can still have um, or sorry, I apologize, seizures worsening in individuals with epilepsy and ADHD. I suspect that you can have like idiosyncratic effects to certain medications, but from the whole part, and Rob and I were talking about this as well, about how, there's just a lot of the individuals with epilepsy have various comorbidities, and one has to try to address both. And I suspect that that's also a failure of our medical system, in that, like psychiatry has become separated from neurology a little bit. And so from my end, I'm trying to learn how to, I've not done ADHD medications yet, but I'm definitely trying to become more comfortable prescribing medications for anxiety and things like that. And simple medications for like dopamine stuff as well. But next slide, please. The other thing is the other interesting thing too is that we have a lot of the anti-seizure medications, as you're aware, have other side effects that can be used, and a lot of them are used in psychiatry fairly commonly. So in general, valproic acid is a mood stabilizer. Sorry, I made a plural, I don't know why. It does result in sedation, and it can, sorry, my spelling's atrocious, weight gain. So in individuals that have low weight, like, when it's kind of a nice one where, say, if a child comes in that has autism and they're very thin because they don't eat, and they don't sleep, valproic acid may be a really good option. And some families do choose that. Sodium channel blockers in general are mood stabilizers, and lamotrigine, I understand, is used quite commonly. And then benzodiazepines, unfortunately, there's a component of um, oh, sorry, I can't think of the word now, but they can be anxiolytics, and can help with sedation. And then there's also medications that we may want to avoid. So something like topiramate can cause cognitive slowing and weight loss. Now, maybe in individuals that are overweight, maybe that's not a bad idea. Or again, topiramate can also help with migraines. So if a child has migraines, then you can kind of play around with it. Levetiracetam and brivaracetam are very interesting. So the logical mantra would say, well, we shouldn't be using it in individuals with autism that are aggressive. But I have had it happen where some children were started on it, and in the outside hospital, and they came in and they're fine. It didn't make any difference at all. And so it is worth a try, as long as the families are aware that there is a risk of worsening behavioral issues. Go ahead, sorry. And then oh, next slide, please. And then again, just to make the point that there are no medications that are class 1 evidence for autism. I think what seems to be that at least for focal seizures, levetiracetam, lamotrigine, carbamazepine can be used. And at least we would probably go for something like oscarbazepine if possible, or even lacosamide. But I think, I think the best way to proceed is to, describe all the medications to the families and then come to a good conclusion to see what might be the best. I think that's it.
Sorry. Right now, Egidio, my understanding is that seizures are fairly well controlled.
Yeah, so those three EEGs were negative, so there were no seizures. So, but again, the rub is he's still having some of those episodes but at least we don't think he's having seizures right now.
No, but unfortunately, his behavior has continued to worsen, and this is where we'll never know what would have happened if he didn't have seizures. I mean, we can't know that. Maybe it doesn't matter, but he continues to have significant behavior problems to the point that his dad has to lock himself in the room sometimes, and they really aren't able to engage in any activities outside the home, despite having a number of behavior people involved over the years. As I said earlier, in elementary school, he only went half days for the most part. When he started in high school, his parents didn't want to send him because that's when the seizures were becoming more problematic and they were concerned about his safety, but also because of the aggression about other people's safety. And I didn't realize this, or I didn't know what happened, but because didn't go to school for the first 3 weeks of his grade 9 year, he was deregistered or unregistered. I don't know what the term is from school, which seems a bit crazy to me. And his parents have never, I mean, they homeschool him during the day and they've got other things, but he hasn't been to school in part because his parents still are very concerned about what might happen with other people with his aggression. And oftentimes what his parents say is that he gets stuck on something and he insists on it and he'll go on and on. If he doesn't, he can become quite aggressive. If he doesn't get it, he becomes quite aggressive to his parents. And his father in particular, it's not at all clear why that is, why his receives the brunt of things. But because he was on the olanzapine, but then because of the fact that his seizures seemed to start at the time he was taking the olanzapine or maybe around that time, and his parents, I think his mom attributes that to perhaps being causal. And so we later tried him on loxapine, which helped. And in fact, I think he's still taking it now at a pretty solid dose. So he's taking 70 milligrams a day, which is a pretty good dose of loxapine. And oddly enough, even with that, he was having problems sleeping, which I'm not sure how. So loxapine is an older mid-potency antipsychotic, which has some interesting sort of pharmacodynamic effects. But even with that, he wasn't sleeping well. So on a small dose of Nozanan, he seemed to do better. He was also taking 5 milligrams of clonazepam. So it's quite impressive that despite the loxapine and the clonazepam, he wasn't sleeping very well at night. Now that also may be because he wasn't engaging in a lot of physical activity during the day because he wasn't going out. And at one point, his parents had said that, as I say, because he got stuck on things and couldn't move beyond them, and couldn't sort of disengage from them, that seemed to be related to a lot of aggressive behavior at times. And so just well, I don't want to say curiosity, but experience with other people, tried him on a stimulant, and his parents actually had said initially that Folquest actually seemed to help him somewhat. That he could be disengaged from things more easily, could be redirected, and perhaps there was a bit less aggression, not a lot, not a meaningful amount, but certainly there was some. And I wonder if that was because it was helping with some of his executive functions with disengaging and from activities. But the fact of the matter is, he remains on a number of medications, seems to have stopped having seizures, but his behavior remains really problematic. And his parents, understandably now, are also more cautious than they otherwise would have been, I think, around starting him on other psychiatric medicines because of the risk, again, of his seizures getting worse, especially given how hard they were to treat and to get him to this point where his seizures are actually a fair bit better right now. And so he remains, a very disabled guy whose aggression is still problematic. But I think it's a really nice example of the difficulties we see in people with developmental disabilities who also have epilepsy. And in fact, Egidio just literally before I joined the seminar or the webinar, the young man I think that you had asked me to see, I saw him, and we could talk about him later. But is again another person with genetic syndrome who has epilepsy uh, and significant behavioral difficulties. So why don't we stop there? Egidio, did you want to say anything else, or do we open it up for discussion?
The only other thing I was going to say was uh just I've been very fortunate in that a lot of like the developmental pediatricians, and so they'll, they try everything, and they throw the book at them, and the behavioral issues don't get better. And so sometimes I get to see those kids, and then I get to we usually start some kind of a combination of a sodium channel blocker and a benzodiazepine, and that seems to help. But the evidence is actually for treatment for behavioral issues in individuals with autism is still, the best evidence is still for your traditional antipsychotic medications. And from what I can gather from the literature, like the various other anti-seizure medications are something to try when everything else doesn't work. But it's been quite it's been very eye-opening to be able to try to manage those kids.
Well, I think your point about the anticonvulsants is well taken, an interesting one, Egidio, because I think in Europe they use anticonvulsants perhaps more than we do in North America for treating aggressive behavior. My experience generally personally has been they don't work all that well, but it may also be because I only use them for people who haven't responded to other things. And so maybe
Yeah.
because it's a selection bias perhaps against medicines being helpful in general.
Yeah, but when they come, like again, it's not as though I have an overabundance, but maybe the
Yeah.
3 children or 4 children that are individuals that I've dealt with, they'd been tried on everything. So by the time they get out to me, then
Yep.
well, there was no other option. So then, but you're right. I think that based on the evidence, I wouldn't start them right off the bat on some kind of a sodium channel blocker. But again,
Well, and I think this becomes the issue because that there are a lot of papers talking about de-prescribing antipsychotics to people for people with intellectual disabilities, and that they're overprescribed. And some of the papers will say, that people, a significant percentage of people with intellectual disabilities take antipsychotics even though they don't have a psychotic diagnosis. I think that kind of statement is a bit misleading though, because they're not taking them for psychotic disorders; they're taking them for impulsive, aggressive behavior. But certainly, they're often used excessively in people with developmental disabilities, particularly more aggressive people. So if people have comments or questions, and certainly the developmental pediatricians in the audience would love to hear from everybody. But first up is the esteemed Dr. Goldberg. So Ben, all you need to do is unmute yourself. Yep,
Okay, can you hear me okay?
absolutely.
I just want to let you know about one of the most interesting patients we had in the 70s. I'll just call him by the name of Richard. Richard had a combination of seizures and explosive behavior, really explosive, aggressive behavior. And I was sharing the medication trials with Dr. George Hinton, who was a neurologist, pediatric neurologist at the time. But for the most part, Richard really was in a quiet room most of the time. He was an inpatient. Finally, I interviewed Richard, who was, I think, about 15 or 16 years of age. This is in the 70s. And I said, Richard, if you had 3 wishes, what would you wish for? Richard was in the mild range, says, I'd like to get rid of my seizures. So George Hinton referred Richard to Dr. John Gervin. John Gervin, who just passed away a couple of months ago, pioneered intracranial electrodes. And he also, after he looked at everything that George had done, said, I think the only thing that's going to help Richard is a hemispherectomy. So Richard had a hemispherectomy because Richard said, I want to get rid of my seizures. After the hemispherectomy and recovery, it just took a few months, Richard was able to be discharged to a group home situation. Now, it sounds like a wonderful story, except the sad part of the ending of the story was Richard was walking across the street in London and was killed by an automobile.
Oh,
Oh, here is this wonderful story that ended up in tragedy. So it's a story that I'll remember to the end of my days. And
but then after the hemisphere, so and for people who don't know, hemispherectomy is literally when they remove half the brain. But my limited experience with hemispherectomies is literally two patients, both of whom were older when it was done, is that they were very disabled afterwards. That they're because I think the idea is when you're young, the brain is plastic, that one hemisphere can learn some of the functions of the other. But the people that I've seen, they were very, very disabled after the hemisphere, more than they had been previously. But I wonder if that's because they were older. But with the patient you're talking about, he did okay after the hemispherectomy, other than being hit by a car?
yeah, it was seemed to be quite ambulatory and had uh, whether it was the left side or right side of the brain, whatever, it was pretty intact. Um, Gervin is, you can look up Gervin, and he's gone through a huge series of hemispherectomies, and he reviewed the literature on it. So, not that I would recommend it for procedure, but we tried everything possible of the medications in the 70s, anticonvulsants and tranquilizers, and I think most of the ones that are available today. But anyway, it's a major challenge.
Oh, well, and so, Egidio, when Dr. Goldberg is talking about the hemispherectomy, I mean, nowadays, if people were going to do that for intractable seizures, would they just do a callosotomy or something?
I
Yeah,
don't.
yeah, it's a good question. I don't know. It, yeah, like there are a few kids now that are, there's a few kids that I've handed over to the epilepsy team, and they all have some kind of a focal change in the brain. So I suspect that they may be able to refine things a bit more now than they used to back then. But if the entire hemisphere is bad, they probably have to remove it. But there's other options too, like there's a vagal nerve stimulator, and there's lots of other things as well.
Yeah, because somewhere, just looking, I used to have an image of one patient I had seen with the hemispherectomy just showing, half the skull is just blackness, and the other half has the brain, but I can't find it right now. But I mean, Ben, you must have a lot, well, you've had a lot of experience over the years, Ben, but I mean, in general, did you find treating people with epilepsy and developmental disabilities harder in terms of treating aggression, do you think?
I'm sorry, were you asking me a question?
Yeah. So, yeah,
Well,
yeah. Did you notice over the years, do you think that people with epilepsy and intellectual disabilities it was more difficult to treat them?
epilepsy and
And an intellectual disability who were aggressive, did you find they were less responsive
less responsive to.
to medications for aggression?
No, I wouldn't think so. I would think so. It was. I think Richard was an unusual case. So most of them were able to respond at the time to the medications that we had available.
Right. Okay. There's a few. Actually, let me just separate these things out. There's a few questions in the Q&A. So first off, somebody asked me a question directly. Dr. Nicolson, how about your patient with a vagal nerve stimulation? Did you notice improvements in him afterwards? So I'm not sure who's asking this, to be honest with you, and I'm not sure which patient. I've got a few that I've seen who've had deep brain stimulation or a vagal nerve stimulation. So if the person who wrote that, if you could just give me initials or something like that, 'cause I'm not sure who you're referring to. And while you're doing that, so there's a question from somebody else, also anonymous attendee. I'm not sure if it's the same person. Question though for you, Egidio, is valproic acid use and elevated ammonia. How common is that?
Yeah, so very good question. Not very common, not as common as one would think. And remember that, actually, the vast majority of the literature actually comes from the psychiatry world on hyperammonemia, but it isn't necessarily dose dependent. So you can have slight elevations in ammonia, and as long as the patient's asymptomatic, there's really nothing to do. I'm just thinking of, so I've been here for 5 years, so maybe 2 or 3 people that have had hyperammonemia. And then there's also that concern of the use of topiramate and valproic acid causing hyperammonemia. And that again is not as common as one would think. And then just to answer Jackie's question, so this is actually the reason I started this combination was a mom actually found this and told me, hey, can we try this? And so what I've done is oxcarbazepine and usually nitrazepam. Like, so it's just a combination that it's in some paper somewhere. So, but there's no reason that something like lamotrigine wouldn't work or but I like oxcarbazepine and I like Mogadon for actually just because it sounds cool, Mogadon.
But trinitrazepam is, I assume, a metabolite or related to nitrazepam, but I think I think it's actually used as a date rape drug also. So you're not proposing that it's not trinitrazepam, it's just nitrazepam or Mogadon. But is there something different about that chemically from the other benzos, particularly?
No, I don't know why. I think it's just something I've learned from like the older neurologists. They seem to really like to use the Mogadon. And I don't know why, but there's no reason why like clonazepam or some other long-acting benzodiazepine wouldn't work. Now, the other beauty is that say if you do start them on, so there's this one girl that Rob knows quite well, but um she actually she caused herself to have brain injuries. And those so she was already on this combination and then started to have seizures and greatly like wonderfully she was already on the right medication combination. So we just went up. So that's the other thing too, is you can kind of cover your bases sometimes.
So the person who'd asked about the deep brain stimulation gave me some more information here, but I don't think the deep brain stimulation, sorry, the vagal nerve stimulation made a lot of difference to behavior. And I've had a number of people refer to me for aggressive behavior who already had vagal nerve stimulators or deep brain stimulators in place already. I remember when I was a resident talking to a neurologist and a neuropsychiatrist at the time, and they said that there, at least historically, had been some tension around behavioral issues with neurologists and psychiatrists, that sometimes when people's seizures are worse, their behavior might be better and vice versa. And I think that goes back to the old idea about why we use ECT in the first place. But I haven't seen deep brain stimulation make a huge amount of difference. Now, interestingly, in Toronto recently, they completed, I think it's published now, a study of deep brain stimulation into the caudate nucleus for people with severe self-injurious behavior. And I think that in an open label trial, I mean, there was no sham surgery or anything like that, but they actually found that it did actually reduce significantly the rate of severe self-injurious behavior. And I have one patient of mine was involved in that study, and his parents have said it was life-changing for them. So that hopefully is sort of a potential new treatment more around self-injurious behavior in those people. And so the other question that came up just now was about the patient being on an SSRI. And yeah, so he eventually later on, he was on fluoxetine and has been on it. And at times we'd increase dose because he was more irritable and things. And his parents said that seemed to help with his irritability and stuff, but not with the aggressive behavior at all. And so the question, and it becomes the really tricky part, was around, what psychosocial interventions were tried to optimize development. So the patient that Egidio and I were talking about, he had at least two, I think he had a community behavior consultant from CPRI and a behavior analyst from CPRI, and is currently, because he's not 18 yet, still involved with the Ontario Autism Program, and has had a private behavior analyst involved with them for probably 8 or 9 months now, and hasn't made a huge amount of difference. And I think part of the difficulty is, and I hope I'm not saying anything that's blasphemy, but I think when it comes to impulsive behavior, I think that's really, really difficult to address sometimes. And I think also at this point, when people's parents are frightened of them because of the aggressive behavior, I think people are become less willing to do behavioral stuff, unfortunately, which is why we really need to do it at a young age. And so a number of attempts were made without a lot of benefit, unfortunately. And then Dr. McLean said, do you find that parents of children and adolescents are now asking for pharmacogenetic testing for children without an optimal response to medications for aggression and seizures? So I don't know about you, Egidio. I've had a number of parents ask me about that. My understanding, though, is all that what pharmacogenetic testing can really do is look at different polymorphisms of liver enzymes and things like that around metabolism, and may help us to understand better the side effects that people may have and what may be at risk for greater side effects. I don't know how good they are at helping us choose between medications for, well, for aggression, I would assume not very much personally. I don't know with depression and schizophrenia how effective they are, but certainly a lot of people have asked. I think unfortunately it's quite expensive. I think it's $400 or $500, and not covered by OHIP. And when I've seen the results that people have brought to me, generally what it's talked about more is what risks there are for side effects with things, not necessarily what will be beneficial or not beneficial. But I guess, Dr. McLean, I will try to pretend I'm a good psychiatrist. I will ask you, what has your experience been with this? And while she's answering that, Egidio, do you have any thoughts about genetic testing?
Yeah, so I was going to say from a neurological perspective, pharmacogenomics, at least from anti-seizure medications, are pretty much, there's not very good at all. The only evidence would essentially be for something like Dilantin, maybe clobazam, so the benzodiazepines, maybe valproic acid. But we don't actually understand very well how like there's multiple CYP enzymes that are CYP enzymes that are involved, and a lot of the medications are not even they're they go through the other pathways. At least the one thing though is that we can measure, like for example, clobazam, you can measure metabolites, and valproic acid, you can measure levels. So there are ways of, if somebody's, we assume that somebody's a very fast metabolizer if the levels are really low, but the pharmacogenomics, from what I understand, in epilepsy are not very helpful.
And Julia, when you said that you mentioned a few medications, I forget which ones now, but is that again mostly talking about what people are at risk for side effects, or is it actually talking about what might be beneficial for them?
I think it's actually beneficial. So
Okay.
if somebody's like ultra fast metabolizer of valproic or Dilantin, you could give them higher doses. So there is actually a bit of evidence for that. And you can see that with clobazam, because clobazam's metabolizes into desmethylclobazam. And so you can see people that have, for example, are very high levels of clobazam, but the desmethylclobazam is really low. So then the assumption is that they must be slow metabolizers. And then that kind of guides, well, maybe we increase the dose and then they might get toxic. But then you can just monitor that clinically, realistically. So, but there's some evidence for management of medications, but it's very limited to very limited medications.
There is another question here. Let me just okay. So Dr. McLean was saying she hasn't been able to unmute herself, but if you put your hand up, I think I have to be the one who does that, Jennifer, if you want to make a comment. But while we're doing, I would wonder if anybody else has any thoughts or comments about how they would approach these things. Here we go. You should be okay to go now, Jennifer. You just have to unmute yourself.
That worked. Thank you.
Yep.
Okay. Yes, the future is going to be precision medicine. We know that, but obviously in the clinical context, right? And just as the discussion was occurring, there is some good evidence for a number of antipsychotics in terms of being able to identify the gene and enzyme coding issues and see what people have. But again, it's within the clinical context. And you've got the problems with cost. Yes, not all covered. You have the problems with different ways laboratories do it and the availability to do it. And then the issue becomes how you look at that within the clinical context. You can't just, it's obviously not alone, but I do know it's sick kids that are having, just because I'm now on this side of the world a little bit more, they're having more and more people asking for precision testing for the reasons you just discussed. And it's really to be able to look at efficacy and also to look at adverse side effects if they had any difficulties with certain enzymes. So I agree with the discussion that's occurred so far, but I think it's going to get better and better. And Mike Reeder's one of the people who's been involved with the pharmacology group through CPS, who has been publishing quite a bit lately together with sick kids.
Yep.
So we'll see more and more coming out.
I think the difficulty is going to be though with that, Jennifer, and I'm glad to hear that about antipsychotics. I wonder though with more heterogeneous things if it's going to be even harder. So with depression, given how heterogeneous it is that going to make it harder to find? I think in looking at polymorphisms for side effects, that's one thing, but to find things that are going to have efficacy, and so I wonder even in talking about people with intellectual disabilities who antipsychotics were not. Well, they were discovered by accident, but they're not intended for.
Right.
Does that make it even harder in this group to find things?
And probably the answer is yes right now, and we'll have to see how the future comes along, but pretty exciting when you think about the concept.
Yep. Oh, for sure.
Yes, yeah. Anyways, that's why I was asking.
Yep, but thank you for that. Thank you, and good to hear from you, Jennifer. Are there other comments or questions people had, or approaches to deal with this? Because this is, I was saying to the boy this afternoon, Egidio, that what I usually do in these situations personally as a psychiatrist, I almost invariably will email somebody's neurologist and just ask them to bless what I'm doing, and to say it's, and partly because I would like somebody else to take responsibility if something goes wrong, but also just to make sure that it's not going to interfere with anything. I think the other difficulty we had with this young man, and it does become a problem sometimes, is not wanting to do two things at once, or trying to avoid that. And so for quite a while his seizures weren't well controlled, we really didn't do anything with the medication for behavior because I didn't want to mess with what Egidio was doing and sort of potentially cloud the picture about which anticonvulsants were helping and which ones weren't.
So, Rob, that's actually a really good question because we were talking about this last night. Is it better to treat concurrently then? Like, are we doing them a disfavor by waiting on one? Because it takes, all these trials, each one of these medications, it's a month or 2 months, right? And then are we, like, is it better to try to tackle these things together?
Well, so I brought up with Egidio last night a young man who was a patient of mine. He was seen a few years ago by a different psychiatrist, and he was very, very aggressive, but also had uncontrolled seizures at the time. And what the psychiatrist was saying was that he couldn't really treat the aggressive behavior because he didn't know what was due to seizures and what wasn't, and what was precipitating things. And the difficulty I had with that is I think that he still had significant behavior problems, which were really having an impact on his family because his parents were getting hurt and he wasn't able to go to school and things. And in that case, I think I would be tempted to go ahead and treat it anyway, personally, just because of the ongoing difficulties. I think what I was thinking about more, Egidio, was if anticonvulsants are being changed, that if you introduce a different medication, if seizures get worse, I guess we wouldn't exactly know why. And as much, I think ideally I try to only do one thing at a time, but it doesn't always work out that way. And especially given that we know that levetiracetam can worsen behavior at times. Again, so if it just makes it really difficult, I think, to do things at once. But sometimes you have to do what you have to do. Did anybody else have any comments or approaches or questions they wanted to ask or say about this? Because this is a problem that comes up all the time. All right, well, Dr. Mitchell. Right, so Dr. Mitchell agreed with me, so I feel positive about that. That it's a common issue, and that often we assume seizures need to be treated first, but as Egidio said, it can sometimes take longer what to do, especially to find the right anticonvulsant, while at the same time people's behavior can still be very interfering for them. And I think, in retrospect, Egidio, I wonder if I should have done something sooner about changing his medication. But I didn't want it because I didn't, obviously at the beginning, we didn't know it was going to be that difficult to treat. And so I wonder if I should have done something differently in retrospect. And perhaps I wish I had now that I think about it. And there is also there you go, Claire.
Yeah, hi.
Hello.
So I just wondered from Egidio's perspective, like, what are your thoughts about trying to treat behavior in the context of uncontrolled seizures? I think sometimes we just don't want to step on neurology's toes while they're bringing seizures under control. But as Rob's pointing out, there's often quite severe behaviors in the interim. So I guess what does neurology have to say about this?
So I can't speak for everybody. So this is just for me, myself, but I've been forced to start to use it's mostly with anti-anxiety stuff for me. But I know that, we know that things like kind of the more like juvenile myoclonic epilepsy or these epilepsy are associated with anxiety. So I'm pretty quick to start. And again, it's not as though I'm starting, 100 patients, but like in the right person, I'm usually starting anti-anxiety medications fairly quickly. So I agree with you. I try to get the seizures under control, but if the anxiety is still a really big issue, I'm trying to be a bit more proactive, but I'm not sure if that's the right answer or not.
But because I think though, Egidio, and this is what parents say all the time, I think the aggressive behavior is what tends to cause the most problems in people's lives, right? That nobody gets kicked out of school for being anxious for the most part. It's really the aggressive behavior and the disruptive behavior that becomes the real problem. And so when I think about this, what young man I was just talking about, the one who had the intractable seizures and really aggressive behavior, I think that I don't know what the right answer is. I think that to do nothing about the behavior, I'm not sure that was the right answer, but I don't like the idea of starting two things at once either, personally.
And I think that Dr. Mitchell's quite correct, actually, because in those patients, right, like so say if somebody came in that had autism and had epilepsy and wasn't on any medications, I'd probably start something like lamotrigine or valproic acid, and because they have more mood stabilizing effects. And if that controls the seizures, but the behavior is still bad, then I'd be asking, you guys for help, right? So that's, I guess, there's a bit of one can buy a bit of time as well. So that's also there.
And so and again, I can't speak for anybody but myself, but if people I refer to me because of aggressive behavior and they're already taking anticonvulsant, normally what I would do is talk to the neurologist about, can we maximize that? Can we push the dose up just to see if we can get more behavioral control without adding in other medications and the attendant risks of that? I mean, Claire, in general, what has your approach to this been?
Yeah, I think my approach has been to, coach the family to work with the neurologist to try to get the seizures under control, and then, look at the behaviors left over. But as we're talking, I think probably just communicating, if seizures are going to take a while to come under control and there are ongoing behavior concerns that we don't think are specifically seizure related, then a bit of communication can go ahead and try something else. And I guess the question is whether we should try to use a sort of mood stabilizer anti-epileptic at higher dose, risking some of the side effects, or use two drugs at a lower dose. And I think you can kind of argue either way on that, on that point, because sometimes I think targeted medication at a lower dose to treat specific things actually works better than just really trying to just find the one drug that's going to get everything.
Yep. Yeah, I would agree with that as well, Claire. And just to go back to something Egidio said earlier when he was talking about the rate of seizures in people with autism. So we know that people with autism who have intellectual disabilities have a higher rate of seizures, and I think it's also people with macrocephaly probably as well. But my experience has been it's people with autism who have seizures often are lower functioning cognitively, and so maybe more difficult to address aggressive behavior anyway because learning is not going to be as quick. So there's all these things that sort of compound each other, unfortunately, and making treatment harder and harder. And as Egidio and I were talking last night, I think it's also, again, as a professional working with these families, it's really difficult. I think having a child with epilepsy, it's got to be difficult. I think for parents seeing their kid have a first seizure must be terrifying, frankly, especially if it's tonic-clonic. But then having aggressive behavior on top of that, it just things compound each other, make everything much more difficult all the way around. So if there are any more questions, it'd be great. We have time still if people want to stick around. If not, let me just, so if people will get an evaluation, if you could please fill that out, and then Jason will make sure that everybody gets their CPD credit certificate for this. And then, as I mentioned earlier, we have, so next month on April the 9th, which is a week after the developmental disabilities, the developmental pediatrics rounds, but on April the 9th, Julio Martinez Trujillo is going to be doing a presentation at these rounds. And we don't know the title yet. And then on March 27th, although it sounds like we're full, unfortunately, we have our annual CPD, continuing professional development, with myself. Sarah Pilon is going to talk about neuromotor disorders, and Egidio is going to talk about the treatment of epilepsy in children and adolescents. And also, just for people to mark on the calendar, we have our annual research day on May 29th at the Great Hall, and there'll be more information about that coming up. And thank you, Jennifer. Any other comments, or if not, we can wrap things up. Okay, well, thank you everybody for joining us. Egidio, thank you very much for joining us. It was, I think, really helpful and certainly raised a lot of questions and potential answers in my mind, so I really appreciate that. And everybody else, thank you for coming, and we will see everybody on April the 9th, hopefully. All right, take care, everybody.